Okay, we're good now. All right, good morning. I am Blaze Bryant, the communications specialist here with the New York Association on Independent Living, or NIAL, NYAIL, as we're doing the webinar today on the social care networks. Before we get into that, I have a few logistical things. Number one is the webinar is being recorded, and I will have the recording made available uh, later this week. Number two, there's going to be the chat is disabled for panelists, and that is, or I'm sorry, the chat is disabled for attendees. This is a screen reader accommodation, so you can put your questions in the Q&A box, which as we get toward the end, Valerie, our Director of Housing Programs, will go over the Q&A and answer stuff as it comes in. And then the last thing is there'll be a survey that will show up in your browser at the end of the webinar, and that helps me as the planner of the webinars just get your feedback and for any future topics. So with all of that out of the way, let's get this show started. And to help us do that is our Assistant Executive Director, Suzanne de Beaumont.
Good morning, everyone. I am very pleased to introduce you to Emily Engel. She is the Director of the Bureau of Social Care and Community Supports. I heard this presentation about a month ago as part of her presentation to the MRT housing providers. And I have to say, hearing about the social care network, all I could think is this is exactly what we need. So I'm very pleased that Emily was willing to come and present here to our independent living community. So without further ado, I will turn it over to Emily. Thank you.
Thank you so much for having me today. My name's Emily Engel. So I'm the director of the Bureau of Social Care and Community Supports. In my bureau, we have the goal of integrating social care into the Medicaid program. And so we have a supportive housing unit, which is our Medicaid redesign team, programs like the Homestyle Housing Subsidy Program and Rapid Program, which is administered by NILE. We also have the Empire State Supportive Housing Initiative under our bureau, which targets those who are 55 plus with a physical disability or chronic conditions. And then our other unit is the Social Determinants of Health unit. And that unit is working really with, historically, with plans to integrate social care into the Medicaid program. So we have medically tailored meal in lieu of services. We've done some work around creating a medical respite certification and trying to reduce barriers for homeless Medicaid members in receiving primary care services. So a huge suite. And then with the 1115 waiver, we are implementing, of course, the social care networks that we're here to talk about today. So I'll be talking about an overview of the social care networks, how the social care network program works, the role of health-related social needs service providers and how to get involved, and then we have some time for some Q&A. So I guess I like to start with what is the vision of this program and why we're doing it through an 1115 waiver. 1115 waiver allows us to use Medicaid funds for um, for things that are typically not covered by Medicaid, I guess to say it simply. So things like housing supports and nutrition needs, right? We all know that they lead to someone's health and to connection of physical health and behavioral health. So our goal is to take this fragmented system to integrate one that transforms how we collaborate across the physical health, behavioral health, and social care. And this really means connecting in community-based organizations and other partners into the traditional healthcare ecosystem and reimagining how we pay for social care services. Equally important is our goal to strengthen healthcare and social care workforce and reduce longstanding health disparities and measure improvements against these disparities. There are a few different components of the 1115 waiver. If you ever want some light reading at night, we have our entire 1115 waiver and the different components of it on our website for folks to see. But I'm going to focus just on the social care networks today. Um, uh, but always can come back if anyone's interested in the workforce force or population health components of it too. So to accomplish this vision of really integrating social care and and connecting, I guess breaking down the silos between medical and social care services, we have to work collaboratively with partners. So social care networks are a network of health-related social needs service providers, and that includes community-based organizations, healthcare providers that will provide the health-related social needs screenings and services to Medicaid members. And the networks are coordinated by a social care network lead entity in the region. They are really meant to take away the administrative burden that we saw in the prior DSRIP waiver. We saw that it was hard for community-based organizations to participate in, for example, value-based payment, right? It was administratively burdensome to, participate in some of the district initiatives. So this is a way, right, for the lead entity to do the contracting with the plans, to coordinate with the healthcare and behavioral health providers and to really make it simple for community-based organizations just to sign up for the network and help people. So that is the goal of creating the social care networks is to kind of join everybody together, have this kind of hub that's able to coordinate the fiscal, administrative, and data side of things and make it easy for community-based organizations to serve people and be paid for those services. The goals of the social care network are to increase the capacity of screening and navigation. The objective is that all Medicaid members receive at least one screening annually, um, as well as for major life events that they might have. And we're using the Accountable Healthcare Communities tool. So there's one screening tool for all of Medicaid, that Medicaid members that we're using. I know there's a lot of screening tools out there. People were using different ones in providers' offices and hospitals, but in order to have very clean and concise data, we are using one tool for the entire waiver, so it's the same across every region of the state. That data from the tools are being collected and brought into our Medicaid data warehouse. The program was designed to reach, broader populations, even when an individual member is not eligible for the enhanced services that I'll talk about in a little bit. Everyone will be navigated to existing resources to help their needs. We also focus on integration across physical and behavioral health and social care sectors and opportunities for cross-sector data sharing. And lastly, it's an opportunity to meaningfully improve health outcomes, right? That's the goal of this entire waiver is to improve the health outcomes and health equity across New York State. We all know on this call, I know we have a lot of housing folks on the call. When someone doesn't have proper housing or doesn't have the nutrition that they need, they don't have good health outcomes. And so through this waiver, we want to demonstrate that providing things like housing and nutrition are going to benefit the person's health outcomes. And it's not only going to save Medicaid dollars, but it's going to improve, right, the quality of lives. So we have 9 regional social care networks. They've been selected through a competitive procurement process in their Medicaid designated entities. They organizations can join multiple networks depending on your reach across the state. And each network has a website with information on who's part of their network, how to join the network. It even has a member-facing page with a self-screening tool on the website. So if a member doesn't want to, call or talk to someone or go somewhere to be screened, they can just go right on the website and someone will reach out to them. So we've been launched since January, and we're at the point where we're ramped up. Members are being screened and navigated to services across the state. Each social care network is using an IT platform that enables the automation of workflows and also allowing, the delivery of services, but that data then to be reported up to the state. Now I'm going to go into the nuts and bolts of the network and how it works. So I mentioned the enhanced population before, and this is a population of focus that was approved by CMS. And so when a member, demonstrates one or more unmet social need, and they are enrolled in Medicaid managed care and meet one of these population focuses, which are pretty broad, they are eligible for the enhanced services. So members with substance use or serious mental illness, people with intellectual developmental disabilities, pregnant or postpartum persons, members recently released from incarceration, that have chronic health conditions, children under 18 with chronic health conditions, frequent healthcare utilizers, such as using emergency room and hospital stays, and Medicaid members enrolled in health home. Certain services, like remediation services, have additional criteria, like asthma to be eligible, um, or, for modifications having a physical disability. Um, I do want to point out on this slide, I like my next slide better because it actually takes you through the member journey in a more practical. But what I like to point out is that, I mentioned all members that are enrolled in Medicaid, including fee for service, right, are screened using the Accountable Healthcare Communities tool. And everyone gets navigated to the existing services. That enhanced population I talked about, right, can receive things like the medically tailored meals or housing navigation. But then at the end of the day, waiver services are temporary, except if it's a modification or remediation. So everyone will, at the end of the day, be connected to existing resources. So what does this actually look like for the member, right? Most importantly, I want to walk through this illustrative example. So we have Danny, who's a single mother who's expecting her second child. Danny often runs out of money for groceries by the end of the month. She calls her regional social care network to see if she qualifies for help. The social care network navigator screens Danny to identify her needs and verifies that she meets eligibility criteria for food assistance. In step 3, the social care navigator creates a referral to a community-based organization that offers food box services. The CBO then contacts Danny to coordinate her food box delivery for her determined service duration. Danny receives the food box delivery, helping her to prepare nutritious meals. Her social care navigator also connects her to the WIC program. Danny receives, in this last step, right, a connection to this network of social care providers in her community that she can access in the future. But also, when you think of the health outcomes of receiving nutrition, along with, her pregnancy and family, there's just unmeasurable health outcomes there and quality of life improvement from getting these services. So I mentioned data being a big part of, um, you know, uh, the waiver and things that the lead entity of the social care networks is administering. So each entity, region has a social care network IT platform, with the features listed on the left. So that's the screening, tool is in there, an eligibility assessment, navigation and closed loop referrals, regional network of social care service providers, the fiscal management and invoicing, and training and technical assistance. So on the right is the IT platforms, and the reason our state is able to have multiple IT platforms is that we're using the statewide health. I'm sorry, the statewide data. Why am I forgetting the name of it? The shiny. We talk in acronyms, and then I forget what the acronyms stand for. But the statewide health information exchange network of New York. There we go. And so our data can be sent to through there to our Medicaid data warehouse. So we're able to collect data on the screening and services and referrals. Of every Medicaid member and share that information. And for healthcare providers and behavioral health providers, they can use their EHR to screen and refer people screenings into the social care network. Next, I'll jump into the role of HRSN providers and how to get involved. So the CVOs and other HRSN service providers are critical partners of the social care networks. The ultimate goal of the social care network program is to create a strong network of community-based organizations and other health-related social needs service providers that are capable of facilitating convenient, equitable access to services that meets people where they are. The social care network is designed to enhance the capacity and expand the reach of community-based organizations and other health-related social needs service providers who are already working to meet the Medicaid members' social care needs today, right? Right now, we are all helping Medicaid members, right? We're all delivering some type of HRSN services. And I like to say that the waiver isn't meant to recreate wheels, it's meant to fill the gaps. So right now, when we think across the services we provide, we know that there's gaps, right? There's things that maybe our grant funding doesn't cover for members, or members that aren't eligible for programs that are under our grant funding. And that's where the waiver can be very essential in helping Medicaid members with their complete needs. So screenings are conducted using, again, that standardized version of the Accountable Healthcare Communities tool. And it consists of 12 questions spanning housing, utilities, food, security, transportation, employment, education, and interpersonal safety. The social care networks will work with entities in their region to offer health-related social needs screenings in different modalities, virtual and in person. We want no barriers for the member to get that screening. So allowing it in different modalities, it helps that accessibilities. We also require accessible times and for things to be delivered in cultural and linguistic competent ways. So social care navigators are essential part of delivering a seamless Medicaid member experience in these workflows. These this is a core tenet of the Social Care Network program. The navigator can coordinate the member's experience to get them connected to services that are right for them, whether these are existing federal, state, or local services or services that are part of the Social Care Network. Having this benefit is one thing, but having the support of accessing those benefits is also essential so that Medicaid members are supported in their search. Community-based organizations and other HRSN service providers also have the option of serving as social care navigators. So they would need to be contracted with the social care network to provide navigation. A navigator is not a clinician role. It's care managers, community health workers, resource coordinators, or other similar roles. And navigation activities are eligible for reimbursement through the Social Care Network program. Um, as we mentioned earlier, there's also some, capacity funding available. Maybe I didn't mention that, but there's capacity funding available to entities that want to join social care networks because we understand, right? This is the hiring of FTEs. This is, maybe uh, splitting someone's time and ramping up the capacity to navigate and help individuals. So there are capacity funds available to nonprofits only that want to participate in the social care networks. So part of reimbursement, there are a few requirements for all contracted providers in the social care network to receive payment for screenings and service delivery. So you do have to be one, of course, contracted with the social care network, be using the the screening tool I talked about. And then either navigating members to a service or providing an enhanced health-related social needs service for the um, um, network. And part of, signing on, I mentioned the capacity dollars, but also the network, the lead entity, pays for your training and onboarding to the social care network IT platform. Here's kind of my more deep dive into payments for service providers. So there is, like I mentioned, you get reimbursed for the services delivered. So if you provide housing navigation to someone, you get paid for the housing navigation. The capacity dollars are in tandem or at the same time as the service payments. So, understanding that organizations need to be able to ramp up so you can get capacity dollars, and capacity dollars can pay for things like a full-time employee, computers, equipment. Anything that you need to participate in the waiver, and then you start getting that reimbursement for the services and the capacity dollars taper down. But the capacity dollars are really funding to like start being able to provide services to members under the waiver. Now, I think everyone's favorite question is how does this work, right, with pre-existing grants from the state, right? And again, I will say this is meant to fill the gaps. Or it can also be, right, another, I guess, line of business that entities can have under their hat for members that they serve. So I guess I'll walk through this example, but then we can talk about housing contracts and how that that looks for us. So under this example, there's a state grant for supportive housing, which reimburses for rental subsidies to eligible population as part of a state grant, housing case management, outreach to identify individuals in need of services, and tenancy supports, right? So the SCN program payments can pay for the screening of the accountable healthcare tool, right? That's separate and distinct from the state grant. Eligibility assessment and navigation to other HRSN services, housing navigation, and community transitional supports. So it's really taking, what services and populations are eligible through each funding source. Where are the gaps? How will you, organize and track how funding sources are being used, right? So I think the point of braiding funding is to be able to pull it apart, right? And know this is paid for by the grant, this was paid for by the social care network. Um, and I think, a lot of times the members that we are serving in our grant programs, they have a lot of additional needs that our grant funding doesn't necessarily cover. So I'll use Olmsted Housing for an example, right? We're transitioning folks out of nursing homes. So the grant is paying for, right, that housing navigation. We're able to pay for the community transitional services under the grant, but there isn't funding for meals. And a lot of times, right, there's a delay in meals. So have up to, I think, 30 days of food. But what if someone needs a medically tailored meal? Or they don't have the long-term ability to provide meals for themselves. So that you can connect them, right, the social care network, or screen them yourselves and navigate them to a meal provider. Or if there's housing supports, say someone isn't eligible for the Olmsted program, right? Olmsted has a certain eligibility criteria, and you don't have a program that they are eligible for under your hat. This is a great time, right? Or ability to use the social care network to make sure that member does get connected to housing services. So again, you can provide the screening, you can provide that eligibility assessment and navigate them to housing programs that they are eligible for and be reimbursed for those connection services. I think my third example, somewhat deviating from the slide, is the social care networks are getting a lot of screening from behavioral health and healthcare providers. Um, they are screening in practices and hospitals, in FQHCs. And those screenings are going directly to the social care network, and they need navigators to help get the members to this enhanced services of the waiver. And so entities can also join a social care network outside of their current funding, right? And provide, the navigation or the housing services to Medicaid members that are outside of their existing grant contracts. So in addition to, joining a network, there's also access to training and technical assistance from the social care network lead entity. So you get the reimbursement for the HRSN services, but there's also training and TA to onboard in using the IT platform. And then also, submitting invoices through the platform is really a seamless process, but you're not, you don't sign up and okay, good luck. There's a lot of TA and training for anyone who signs up for the networks. I think for this last slide, I'll just say we have a ton of resources on our website, that so do the social care networks. So if you're interested in digging in on more information, or you want to see more Medicaid member facing information, you can see that all on our website. Okay, I will pause there for Q&A. I know that's a lot of information, kind of a firestorm.
We do have a couple of questions for you, Emily. The first question states, if people are in one of the target populations for enhanced services like IDD, but are in fee-for-service Medicaid, they will not actually be eligible for those enhanced services. How does this make sense?
Yes. So fee for service will be navigated to existing resources. So they are eligible to be screened. They get the eligibility assessment, and then they'll get navigated to existing services. With the federal government, this is a managed care waiver. But we wanted and thought it was important that all members get that navigation piece, but it is focused on Medicaid managed care.
Thank you. The next one says, will you talk about how you are ensuring effective communication, especially for those who are deaf, blind, whose primary language is ASL? Also, how you are ensuring effective communication for people who communicate and process information differently.
Yeah, the social care networks have done a great job of this. They've contracted for ASL services. They've taken the Medicaid member materials and made them ASL friendly. So each social care network is making sure that it's very consumer driven, and that communications are for all different languages and disabilities. So, yeah, each social care network has that on their website as well as in their offices. Again, they're working through community-based organizations, right? The lead entity is really just the organizer or the hub. So the each social care network is leaning on community-based organizations that specialize in different disabilities and populations in order to effectively target Medicaid members and get people who need the most help those services.
The next question you answered just a little bit in talking about Olmstead, but there is some questions about the type of housing subsidy that the SCN would provide. So the question states, finding affordable housing for consumers has been a big challenge for me. Does this waiver allow programs for individuals that do not qualify for Olmstead to now qualify for the same kind of housing subsidy?
So these services are temporary. So it does have up to 6 months of rental subsidy. And the rental subsidy, I'm sorry, not the rental subsidy, but the social care network would really connect the Medicaid member to other resources of rental subsidy programs. So maybe it could be a state OMH program, an MRT program. It could be with a housing authority or HUD vouchers, if those are open in the area. Can be a little tough. So it's really connecting them to long-term rental subsidy. But we can pay up to 6 months of rental subsidy. We can also pay back rent if someone is in arrears so they don't lose their housing. But again, it's temporary.
Thank you. The next question says, how does a gap in services get reported?
I'm not sure what you mean by that. A gap in services get reported. I think that's if you're working with an individual Medicaid member or on a particular program, and I'm just going to use Olmstead again as an example because that's near and dear. So if someone in your Olmstead program is struggling with food security, right? You can then either refer them to the social care network or you could do the screening. You get paid for that screening if you're contracted with the social care network, and connect that member to a medically tailored meal program or a food prescription box program. Depending what the member is eligible for. So I think in identifying gaps, there's a lot of things that grant funding won't pay for, or people that aren't eligible for the programs that you administer. And so that's what I meant by gaps is identifying services that people need that aren't covered, or people that just they need the help, they need the connection, but they aren't eligible for your current grant funding.
Thank you. The next question asks, does this funding provide for assistive technology?
No, there is an assistive technology part of the funding. And I'm sorry, I thought I had a slide with all the services on it, but I can do kind of a quick overview. For housing, it's housing navigation, community transitional services, there's pre-tenancy support, there's post-tenancy support or tenancy sustaining services. Again, that's up to 6 months. There's up to 6 months of rental subsidy and utilities, and then there's the back rent payment or back utility payment, and that's our housing bucket. Under the nutrition bucket is medically tailored meals, clinically appropriate meals, food prescription boxes, and pantry stocking. And then there's also transportation. Transportation related to health related social need services or care management. So, for example, housing interviews, right? A lot of times people have to get to a housing interview and there's no way for them, they don't have a car, they can't drive. The waiver could pay for that person who's engaged in care management under the social care network to get rides to their housing interviews, things of that nature. And then um, the screening questions do ask about employment, education, and interpersonal safety. Like I mentioned, there's no actual services under that. That's more connecting to our existing state programs.
Okay. How does the assessment differ from the SDOH assessment currently being used?
I'm not sure what you mean by a SDOH assessment. So there's the Accountable Healthcare Community Screening Tool. And then once a member has an unmet need identified from that screening tool, they do get assessed. And that's kind of a deeper dive into what the Medicaid member actually needs. So, for example, with housing, they say they're afraid or they might lose their housing. So then there's a lot of follow-up questions to that, right? Do you have an eviction notice? What's going on with your housing situation? Are you receiving any other type of subsidy assistance right now? And then we can navigate or help connect them to the best enhanced service possible to help them. So the assessment is really diving into what the member actually needs and what service is going to help them.
Who is supposed to contact and assess people in fee-for-service Medicaid, and when is that supposed to happen?
So this is all happening now. So fee for service, Medicaid managed care, all Medicaid members, I'll say, can be screened and navigated through the social care network. So it's a no wrong door approach. It could be a community-based organization. It could be a healthcare provider, behavioral health provider. Hospitals are screening. It could be a member who goes on the social care network website and does the screening themselves. But yes, it is all members are being screened now as we speak. We want more people to participate in screening, and by people I mean organizations to participate in screening and referring members into the social care network. We need that for this to be successful. So if you're interested in being reimbursed for screening or navigation, reach out to Social Care Network and they can sign you up for their network, and you can screen fee for service members and be paid for it.
Is there a different reimbursement for the assessment and for the linking, or does both need to occur to bill?
Um, so there's a whole fee schedule, but there's reimbursement for just screening. There's reimbursement for the eligibility assessment and navigation. And then enhanced navigation has more, I guess, units to it. I think it's up to $350 a month or something like that. Because that's going to be a little bit more hands-on and intensive, I would say, for the enhanced population versus the folks that are just getting navigated to existing services. So that's all built into the fee schedule, which each social care network has. And it's also in our manual on our website.
So another question regarding the reimbursement, it says an agency pays the rent and gets reimbursed through billing. Are they reimbursed only the actual rent expense or the full cap amount on the fee schedule?
So if someone's paying rent, the 6 months rent, it goes up to fair market rent, for the member. Um, I don't know if that answers the question.
Didn't provide more information. I'll see if they pop back in with more.
Yep.
Another question is there a referral form to submit to the program?
It's not a referral form, but there's the screening on each SCN website. So if you don't want to get paid for the screening for some reason, you can just refer members to the screening on the website, or each social care network also has those marketing materials I talked about, and they have phone numbers that they can call. So whichever their preference is. Or if you join a network, you can screen members and refer them in directly and get paid for that.
When they say, do they provide other needs such as social security or housing needs like furniture if someone needs it? I assume they're talking about the navigators.
Yeah, navigators will connect to existing resources like Social Security or WIC, SNAP, TANF. And then for the community transitional services, they can pay for furniture, housing, what am I trying to call it? Like pots, pans, sorry, that type of thing. There's also, I didn't mention this before, and I should have, cooking supplies, so they can pay for a small refrigerator, plates, pans, things of that nature as well, under the waiver.
Um, if the navigator identifies a need for transportation and the community member is eligible, yet there are no transportation options in the area, how does the navigator report that gap?
So this transportation under the waiver is limited to social transportation. There's no medical transportation under the waiver. But if a Medicaid member, say, needed help getting their food monthly or something like that, they could be referred into the waiver. There's a transportation question, and they could receive the HRSN, health related social need transportation through the waiver. Same thing with the housing interviews example, but it has to be health related social needs, and it has to be through the process I described of having the unmet need, being in Medicaid managed care, the enhanced population, and then needing transportation for those services. And again, that is a temporary service.
Thank you. The next question says, if an individual has a rental subsidy through, for example, OPWDD, but they are in arrears with their utility bills, would they be eligible for assistance through this waiver?
So as long as that's not something that the grant through OPWDD covers, they could be eligible for the waiver services if they meet the criteria. But that would be a good example of identifying the gaps, right?
Somebody had a question. I think it's more of a housing situation regarding the 6 month time frame regarding rent.
Mm.
So housing on a temporary basis creates the possibility of unstably housed or homeless all over again. Many of our participants have disabilities and deserve the comfort of knowing they have housing long term. What if none of the subsidy programs are accepting applications within the 6 month time frame?
Yes, no, this is a great clarification, and I'm sorry, I meant the housing for 6 months rental subsidy is only when a member gets connected, right, to a long-term source. So, for example, if they get connected to public housing authority, and they'll be using that, we could provide 6 months temporary while their supports are getting set up. But it's not long term. And we would never ever place someone in housing where there's not a sustainable. Another good example is Olmsted, right? We have folks on the Olmsted program that are one shot. They don't need long-term rental subsidy supports, right? They could access maybe 6 months rental subsidy to get them started until they're able to pay their own rental subsidy. But this is part of the navigator's job is to make sure that they have a sustainable housing, and it's not something that's going to go away in 6 months. So the 6 months is really used as a bridge to programs, and the navigation it is ongoing until the person finds housing. So we'll pay for the housing navigation, and that can keep getting renewed as the member continues their trying to find housing with the navigator.
Back to the question at the beginning where somebody asked about gaps in service. She states she apologizes, she was not clear. But the example is someone who is a CDPAP consumer and needs a designated representative to help navigate the role of supervisor for his or her aides, but has no natural supports to fill the role. And there's no formal service to provide such a representative. What would the response from a navigator be if there exists no such service?
I still a little confused on the question, sorry. And I can provide my email too after this, if there's uh if it's better to take it offline. But um if they have a representative, they can speak on the behalf of the member to the navigator. We do have that set up where designated representatives can help speak for the member with the social care navigator. So it doesn't necessarily have to be the member. Same thing with a family member. If they're the executive, they can speak for the member.
I think the question is more about the person does not have a family member to speak on their behalf, does not have, they're looking for that representative. And how do we fill that?
Oh, yeah. I know there's some existing programs if it's not court appointed, but that's a little bit nuanced, so we can take that offline if it's helpful.
Is there a referral submission for acceptance? I think you've already answered that question.
Mhm.
Can we get the reimbursement details?
Yes, each social care network has their fee schedule. Some of the information is on our website as well. If you go to www.health.ny.gov/social care, that's our website and has our manual on there that has some of the information on the fee schedule.
Okay, a couple more questions, and then there's several more, but we'll get through a couple because we appreciate your time and want to make sure that we don't take up too much of it. When a participant transitions back to the community from an institutional setting, are they screened automatically for SCN qualification of the enhanced service, such as medically tailored meals?
No, so it's not automatic for Medicaid members that are transitioning back to the community. We would need service providers that sign up with social care networks, and they could say, "Hey, we're going to target folks transitioning from nursing homes back into the community, and we want to do this screening for these members." And then the social care network would pay them, but it's not automatic or built into our processes. It's a
And if
gap.
they, right. And if they are approved for the medically tailored meals, how long do they receive those meal box services for? Is it a monthly? Is it a yearly service?
So all our waivers services go in 6 month increments. So it's up to 6 months with the ability to renew. Yep.
Um, what would a navigator's response be to the lack of PCAs who are available to travel and work with families who live on Eastern Long Island and past a certain point? Example, Patchogue, New York.
So the social care network, again, is focused on community-based organization. This is a community-based organization hub. It is not medical. So they are helping Medicaid members with their social needs. They are sometimes referring or, trying to coordinate with the healthcare space, but their sole purpose, is the social needs of the Medicaid member that are identified by the Medicaid member, self-identified.
Um, does the navigator only refer to the contracted entities, or do they include referrals to other entities that are not in the SCN as well?
Um, Sorry, Valerie, can you say that one more time?
No problem. Does the navigator only refer to the contracted entities, or do they include referrals to other
Mm.
entities that are not in the SCN as well?
They can refer to entities outside of the social care network, yes. For the enhanced services, though, you have to be contracted with the social care network.
Okay, so then another question kind of alongside of that says, does a provider have to successfully transition a participant from screening to navigation or case management before getting paid for navigation or case management?
So they're all separate billable activities. So you get paid for screening, you get paid for the assessment, and you get paid for the navigation. So they're three separate, and you're billing for your time associated. So I mentioned the navigation or care management of the enhanced population is up to $350 per month, I believe, just off the top of my head. And so, but you're doing within, I think it's 15-minute increments you can bill. So it'll vary per Medicaid member. But say you only spend, I don't know, 30 minutes with Emily Engel and she just needs a referral to medically tailored meal, you would get paid for that 35 minutes. And then maybe I have other needs too, but that's what you help me with immediately. You can bill for that time and continue to help me and
Okay,
continue to bill, if that makes sense.
and last question, I'm going to combine two questions together because they're kind of hitting on the same. So to expand on social transportation, can this transportation be provided not only for housing related matters to reintegrate and get out of the nursing home or hospital, but can this social transportation also be for those who have to go to the local DMV, HRA, or DSS, or Social Security offices to receive those vital documentation?
So yes, if someone needs to go to the DMV because they need a driver's license or non-driver ID in order to get into housing, we do see that all the time. Then yes, the social transportation through the social care network could be used for that purpose. Yep.
So with that being said, is there a way to clarify what social services are not included, social versus medical transportation?
Yes, in our website, we define social transportation and what's eligible. And that's on our website.
Awesome. And I'm going to stop it there and we'll provide out your email address if people have more specific questions that they would like to ask you directly regarding these programs. And I just want to thank you, Emily, for joining us today and explaining this out for all of us. This will be a vital service that we can all tap into. And we really appreciate your time today.
Thank you all so much. I appreciate it.
Emily, thank you very much. And Valerie, you you handled the Q&A like an absolute pro. So thank you very much for doing that. Much appreciated. Uh, we will have a webinar coming up in July. I'm still finalizing some of the details for that. The recording and the slides, you will get those along with Emily's contact info because Emily, I will include you on the email with all of that stuff. So you have everything and folks can reach out to you. So with that, thanks to my team here at the New York Association on Independent Living for everything they did to make this happen. And special thanks to you, Emily. I'm Blaze Bryant, and we'll be back in July for our next webinar here in our webinar series. Have a good day, everyone.
Thank you, everyone.